you for joining us for this educational program on Becker muscular dystrophy. I will hand it over to our presenter, Dr. Verma from Emory University School of Medicine.
Thank you, Erin. I'd like to thank the MDA for giving us the opportunity to present on Becker muscular dystrophy. In particular, I want to thank Erin, Suja, Kathleen, and Veronica for helping build this program, also helping me with the all the material. And I'm hoping we can learn from each other today on the advances in Becker muscular dystrophy and also what's changing and what can we do better. Our objectives for the day is going to be examining some of the close relationship between Becker and Duchenne, and also how we call it a spectrum or dystrophinopathies. We're going to be looking at some of the differences which are available, or so to speak, lack of knowledge on how to manage Becker's, as a lot has been done on Duchenne, but very limited information on standard of care of Becker muscular dystrophy. We'll use an example on how one can come across these cases in your day-to-day practice or in your neuromuscular clinics. One of the key things I thought would be interesting to learn would be what is the natural history of Becker and what are the available data on this, and if that can help guide us. And finally, we will discuss some of the clinical studies which are ongoing and opportunities where we all as experts in the neuromuscular field and colleagues can come together and and advance the field. So I thought of using the word a changing landscape, although I must say that the landscape of Duchenne is probably much more likely to change than Becker right now, but they have cross currents and influences. So it may be worth looking at Duchenne and Becker, or Becker, and that's why we use the word time to reevaluate. We're going to do some case studies, and then we're going to summarize our program with some of the thoughts which are available and take your questions. Let's start with the incidence of dystrophinopathies. I would use the word first. We know quite a bit of Duchenne muscular dystrophy, and with the advancements which are occurring, especially initiatives like newborn screening, which may be hopefully starting in Duchenne as well. There is a lot to learn about the incidence in Duchenne being 1 to 3,500 to 5,000 male births. But Becker muscular dystrophy, the estimates are not very clear, and it is, I thought of using the word like a tip of an iceberg, because there are several people who go undiagnosed during their lifetime because they may not have symptoms. Yet it is estimated to be 1 in 18,000. If you put together all these patients, about 1 to 2 patients per 10,000 males between ages 5 and 24, and similarly a slightly higher number when you're looking at younger kids, which probably more of the Duchenne boys who come to light early in life around 4 to 6 years of age. Dystrophin is an important protein. It's a cytoskeletal protein which is located in the plasma membrane or the sarcolemma and help maintain the integrity of the muscle membrane. Here's a cartoon on the right side of my slide, which shows the N-terminus, the rod domain, and the C-terminus. And this is an important component of the integrity of this whole sarcolemma. In absence of this protein, the muscle starts to break down, and that particular leads to attraction of inflammatory cells, and then leads to further damage, fibrosis, contractures, and causes muscle weakness. Now, the disease mechanism for Becker and Duchenne are on the similar lines of this dystrophin being absent or abnormal, but on a variable spectrum. This is a nice slide which kind of defines what that spectrum looks like. So with the absence of dystrophin, which is usually you do immunostains on the muscle membrane, you get a very severe phenotype with muscle breakdown, muscle damage called Duchenne muscular dystrophy. Whereas somewhere in between, those patients who have milder absence of dystrophin or moderate absence of dystrophin will be in the intermediate phase. And the ones who have mild dystrophin or absence or more of the higher staining as seen on these slides, immunostains, you would see that they will have a less severe disease and more would be in the form of Becker muscular dystrophy. On the bottom of the slides, you also see the H&E stains, which are showing a muscle which is greatly affected on the right-hand side with inflammatory cells. You have variable fiber types. You also have increased fibrosis in the tissue and degenerating fibers or disintegrating fibers. And as you scroll towards the left side, you see that that particular inflammation starts to become less and the muscle architecture is much better maintained. And that's usually the reason why Becker patients are much milder or quite variable, so to speak, with their presentation, may not have symptoms at all, or may have very minimal symptoms. This also leads to the difference where disease onset could be a little bit later and the progression could be much slower. Whereas in the severe form, like Duchenne muscular dystrophy, the disease onset is very early, and the damage could in the muscle or the inflammatory changes could lead to progression of the disease and early contractures and loss of ambulation. This is a busy slide, but what I want you to take home a message is that there are several overlaps which can happen in these cases. Although the presentation can be quite variable in Becker versus Duchenne, which tends to have a more well-defined presentation and course. To understand Becker, I think it's important to first know Duchenne muscular dystrophy very well. So Duchenne boys, as we all have seen, start to present around 4 to 6 years of age with muscle weakness, difficulty walking, toe walking, and then they would often have the very classic Gowers sign with the calf hypertrophy. There are also often heel and Achilles contractures or heel contractures, and that leads to frequent falls. There could be weakness, which is also seen in the shoulders. And the phenotype is much more well defined in Duchenne muscular dystrophy. They have other complications as they get older, especially cardiac, and associated learning difficulties in young age group is not uncommon. That can lead to some anxiety, ADHD features, or autistic traits as well. On the other hand, I must say that Becker muscular dystrophy is quite variable. It can present to you just with a very mild muscle weakness, or may have no symptoms till a child undergoes a very severe rhabdomyolysis and comes to clinic or to the emergency room with dark color urine. There could be kids who have strong family history and could present early because there is a sibling who's affected, or there could be kids who could have something similar like Duchenne with some calf hypertrophy and proximal weakness, but never that severe to have falls as much as like Duchenne. So more on the variable side, quite a different presentation. We've seen cases where there's clinically nothing on the neuromuscular exam, but they presented to the cardiologist with the cardiac issues and eventually were diagnosed with cardiomyopathy and later on genetic testing found to have Becker muscular dystrophy. So it could be a very silent disease as well. And cognitive impairment is not as common as you would see in Duchenne muscular dystrophy. And that probably goes back to the second slide I showed you about the extent of dystrophin missing in these both cases. And as more and more knowledge is coming on dystrophin being a very important protein in brain development as well. So that kind of probably reflects that Becker may have less cognitive impairment. I borrowed this slide from Dubowitz's book on how very classic Gowers maneuver. I thought it would be important for us to also not forget that the classic findings are still there, but in Becker, they may not be present and may be quite variable. Uh, However, it's important to keep in mind that muscular dystrophy features are as mentioned, enlarged calves, Gowers sign, a classic posture as they try to raise a stand up, and on testing, whether it's a pediatrician or as a adult neurologist or a pediatric neurologist, you're measuring their CK when you see a weak child, it's quite elevated, and that that itself sometimes it's hard to kind of tell if it's a Becker or Duchenne, but many in cases the Duchenne patients have very high CK, 10 to 100 times sometimes of normal values. Uh, I also wanted to talk a little bit about certain symptomatic or carrier patients, which can, especially young women and girls who have a family history of Duchenne in their brothers or in their uncles, and they would also have some symptoms, could also present with high CK and could have something similar like a mild weakness or mild phenotype, which could be something similar like we would see in a Becker-like patient. Although here, because being a female, it's a female carrier, majority will be asymptomatic again and do not have as significant cardiac involvement, except a few small percentage of females who can have that. So going back to the understanding of Duchenne and Becker muscular dystrophy, I, I this is a slide which shows the dystrophin gene, which is on the X chromosome. It's a large gene which has 79 exons, and the mutation in the Duchenne gene really, depending on whether it's in frame or out of frame, would define this phenotype or the Becker versus Duchenne. So on the left side, let's take an example. For example, here, in frame deletion of exon 48. So 47 does align with 49 and it's in frame. So this would lead to a more truncated dystrophin production or partially functional protein. Whereas if you remove 46 or delete 46, 45 and 47 will be this will be an out of frame deletion, as 45 does not line up with 47 and will have a no dystrophin production. So this is very much one of the common scenarios when you would see is about 60% of the time there are deletions in these disorders. But then when it comes to duplications and point mutations, it becomes very difficult to give a projection whether this will be a severe or not. However, there are some ways which we will talk about in the next few slides, and looking at obviously the exam is a big one, but also maybe investigating and a child whether it's whether this is going to lead to more of a Duchenne or a Becker phenotype. I also thought this is a given example of an in-frame duplication of exon 48, for example, the same exon which we talked about here earlier, would lead to a more partially functional protein. But if you have out of frame duplications of 46, that will lead to a nonsense mutation and non-functional protein. The distribution of DMD gene mutations or variants is most centers would have a similar kind of pattern. Like at our centers, we have seen 60 to 65% of being mostly deletions. Point mutations tend to be about I would say 20%, and about 8 to 10% being duplications, which is very common. Now, coming to Becker, there is not as much knowledge, as the number of Becker patients seen in clinic is less. So the ratio being like 120 of Duchenne to about 40 of Becker, so about 3 times more Duchenne patients than Becker. So the numbers are a little less to kind of give a good idea, but based on the available literature, they run on the same part. Like there's about 85% of them have deletions, and the rest being point mutations and duplications. There are certain hotspots which are common in Becker muscular dystrophy, and that would be something to be of interest so that you can help look at the natural history or explain to the family, and we'll go over that in a minute. 70% of the mothers are carriers in Duchenne muscular dystrophy, and then there is a data saying that it could be as high as 90% in Becker. But again, these numbers are not as clear as we would love to know because of the less knowledge on Becker muscular dystrophy and also smaller number of patients being studied. So going back to the question I was saying earlier, that if you have a point mutation, or for that matter, you have a duplication where the reading frame is not as clearly projecting towards Becker Duchenne, then there are some ways you can help besides doing the good clinical exam, following those kids and looking for how their course is. Immunocytochemistry or Western blot for the muscle, especially the immunostaining, could be helpful. This is a slide I borrowed from one of my colleagues here, who we had a patient where we had the similar question, and if you notice on the left-hand side, the N-terminus dystrophin staining was less as compared to the control specimen. And similarly, the rod domain and the C-terminus was relatively preserved. So this patient fit well with the Becker muscular dystrophy, although the knowledge on how to quantify these stains and Western blots is limited, and only few labs have the ability to do this kind of advanced work. So many of us would be left with mostly clinical and genetic data to kind of help understand whether this is going to be more Becker or intermediate or Duchenne-like. Once you get these patients in the clinic and you are making a diagnosis of Duchenne muscular dystrophy, there is a lot of available standard of care guidelines, and several organizations, including MDA, have excellent resources for families and how to follow along, especially when it comes to management with, say, steroids or bone health, cardiac, physical therapy. These clear guidelines are not well developed in Becker muscular dystrophy, and often we would borrow them from the Duchenne world. And as a pediatric neurologist, many a times, especially if you're an intermediate form of muscular dystrophy, you often lean towards going for what you would follow for Duchenne boy than you would, because there's no clear-cut guidelines for Becker. I think what's missing also is quite a bit of natural history studies or understanding of how these diseases work. So that's probably one of the reasons that we are not able to develop set guidelines or set procedures, let alone procedures, not even knowing when would be a good follow-up, like would it be a year long or 6 months or every 2 years. So these are important challenges in our field, and I think best practices can help, or developing best practices would help us and our colleagues in making some decisions. The other big challenges which are starting to arise in our field is these early diagnosis of Becker and Duchenne. So with the advent of genetic diseases and also genetics testing, we have been able to diagnose several of these patients very early. For example, I would say child with developmental delay or child with some low muscle tone who does not have a very clear family history would get evaluated and will get a chromosomal microarray and would often be diagnosed with Becker and Duchenne at that time. So that really brings up new challenges, and especially when it comes to milder in-frame mutations, or the CK level maybe normal in sometimes some of these cases, like almost like a posse symptomatic or asymptomatic kid. Then the other challenges is that the Duchenne muscular dystrophy in particular has been really having there are several newer treatments which are coming along, especially availability of steroids, exon skipping, and gene replacement therapies. So we're moving the envelope in the way that many of these severe spectrum kids are becoming more of the intermediate or milder, and that would frame up another set of population. And it also behooves that what should be the BMD treatment then, or Becker's treatment? Should it also be similar in those lines? Should we do steroids, exon skipping, and placement therapies eventually in the future? So that whole treatment guidelines which are being developed, or treatment pipelines which have been developed for Duchenne, will eventually be used towards Becker or not. Finally, I must say that the advancements in cardiorespiratory care has been very much a good thing in one way, but also its application to Becker, for example, and heart transplants have become more and more feasible in pediatrics. We're getting more and more therapies which are available for cardiorespiratory failures. So these patients, especially for Becker, would have implications. So what are the common treatments which we usually use and often necessitates care is getting a cardiac evaluation, also checking orthopedics, and especially if there is changes in the pulmonary function tests which are often done at the MDA clinic visits, then having a pulmonologist at least discuss with them some of those early lung recruitment strategies and vaccinations. Physical therapy and occupational therapy are probably one of the most commonly used therapies for these patients to help, especially prevent contractures, or strengthen their core. Not so much as nutrition, pain, psychosocial, and palliative, which are more reserved for, I would say, Duchenne muscular dystrophy. So among the top 3 or 4, I would say, which have been commonly used, again, without any without any obvious knowledge on the therapeutics or the standard of care, as cardiac, pulmonary, ortho, and the physical therapy. This brings me to a little shift here, because I thought it would be important for us to understand the therapeutics of the Duchenne muscular dystrophy and what's happening there, and how does that influences Becker muscular dystrophy. So last, I said 3 or 4, 5 years, I've seen at least 4 or 5 newer drugs in the field of Duchenne muscular dystrophy, including most recent gene therapy, which has been FDA approved. These therapies are changing the way we treat patients, and families are more and more excited about the use of different types of steroids. Prednisolone is one of the, or prednisone is one of the most commonly used steroids in our clinics, and that followed by deflazacort, which is mostly for kids who have a lot of weight gain issues or mood issues. And then more recently, vamorolone, which is a dissociative steroids, have been approved by FDA for this group. We have not used steroids for Becker muscular dystrophy in the past, but there has been interest in knowing that if steroids can be useful, as there is also an underlying inflammation which is affecting muscle, but again, very variable, and we don't know if this is severe enough. And also, there are other strategies which have been used in muscle diseases. For example, we have seen myostatin inhibitor. We have seen more recently an approval for histone deacetylase inhibitors, and then other forms of therapies such as antioxidants or metformin or tadalafil. And that has all been used in Duchenne and now slowly trickling into the Becker muscular dystrophy field. So let's talk about some of the fewer therapies which have been going on in Becker. There was a recent single center open label study which evaluated once a week prednisone for Becker muscular dystrophy boys, but was not able to recruit much patients in Becker. So it was not able to conclude whether it's safe or efficacious. And it's again challenging because to find or recruit Becker patients in these studies is kind of difficult, as most of the clinics are heavily engaged in Duchenne research, and Duchenne often overtakes many of the drug trials and time from physicians and the research coordinators. And that's again very much the case because it's a severe disease, and it should be important for Duchenne to be addressed at first. But that having said that, Becker is muscular dystrophy is facing challenges because of the decreased recruitment and I think also must say that there is not enough knowledge around that these therapies are available or can be tried or these studies are available. So one of the emphasis of doing this particular talk would also to kind of encourage people to discuss, are there any clinical trials available for Becker muscular dystrophy? Are there any therapies which can be given? Because without those knowledge, most Becker patients are often diagnosed and forgotten and not coming to clinics regularly. There has been several clinical trials in ongoing for Becker now. Especially, I want to highlight a couple of them here. Is the myostatin inhibitor, which is Edgewise drug, epicatectin, which is an antioxidant, the vamorolone, which I was discussing earlier, an NF-kappa B inhibitor. Givinostat, which was recently approved for Duchenne, has been also in the trial for this particular for Becker muscular dystrophy. So let's dwell into a little bit on the natural history studies for Becker muscular dystrophy. Unlike Duchenne, where there has been several groups which have done excellent work on longitudinal um, uh, b- um, like functional scales, especially 6-minute North Star ambulatory or timed functional tests. There has been quite a bit of scarcity of data in Becker muscular dystrophy. And again, that goes back to not a whole lot of testing is done and because the kids are relatively strong and they're not part of any treatment trials and not many uh, therapeutic strategies, or for lack of clinical trials, those are not commonly addressed in the clinic. However, the centers which are doing this work and are following these patients have, again, the other big issue is not enough patients at each center. So there has been a couple of good studies in the last few years, one from the Italian group and the other most recently from this cooperative group here in United States. And we'll discuss both these studies. And they've been able to collect at least 70 to 80 patients in each study and followed these patients over a period of time. Now, provided this time period window is short, but they have been able to get patients from different age groups and track them over the period of time. The measures used are pretty much similar as to Duchenne, like 6-minute walk distance, walk test, or North Star ambulatory assessment, and time function, especially the rise time or the climbing the stairs and the climb velocity as well. So the Italian study of Becker muscular dystrophy from ages 6 to 69, this is on the right-hand side. The curve is showing there was a nice divide of the outcomes based on their deletions, or which is listed on the on the bottom. Patients who had deletions in exon 45 to 47, I would say, would be the ones who had the most significant decline, especially starting ages 18 to 20. And this could be an important point because when you're counseling families and they're, especially if you know their mutation is in 45 to 47, they can be told that there could be a more challenging road ahead, especially with walking into their 20s and 30s or even 40s. On the other hand, when you look at mutations which were in the exons up to 51 or deletions in exon 48, they tend to have a relatively much better preserved course. And this was seen in the study in the United States as well. So I'll move to the next slide. Okay, good. Sorry. So this is the longitudinal study from the synergy group Becker. We also looking at the climb velocity. And if you look at the bottom x-axis, the age group of the patients was uh, from 5 to 18 years, had a pretty stable course. And the mutations which are listed in the color 40, 45 to 47, the green is 45 to 48 and others. The 45 to 47 had the most consistent decline, as you notice, compared to the other groups, which were more relatively preserved. So, but overall, both these studies were very commonly suggesting that it's quite a bit of a variable progression in outcomes in these diseases, in Becker muscular dystrophy, and significant heterogeneity of clinical phenotype. And one other thing which was common to both studies was that the progression started later in age, from 20s to 30s to even beyond that. So in the pediatric age group, we do not expect a whole lot of changes in these patients, but as they get into young adulthood and they will face problems. And that's the challenge, because many of these patients, when they come to pediatrics and they get diagnosed with Becker and they're not showing any change and they're doing well, often have a false sense of that they're going to do very well. But eventually later in life, they can have progression, especially the heart, which we're going to discuss next, can be a problem. Let's see. I think there you go. Okay. So the cardiomyopathy is an interesting part of the Becker muscular dystrophy, and I think is a very important aspect to be covered. We all know that cardiomyopathy is the leading cause of death in Duchenne muscular dystrophy, and most patients who are beyond 10 years of age would need more frequent follow-ups, require ACE inhibitors to prevent heart failure, and then eventually, as they get into their teens and young adulthood, would develop more severe cardiomyopathy requiring supportive care. Although Duchenne muscular dystrophy being a more severe disease, there is not as much emphasis on heart transplants and supportive care on those lines. But with Becker being more on the milder side, if you have an associated cardiac involvement, there is more enthusiasm in the field of cardiology to do heart transplants and do supportive care. So, and also as a pediatric neurology and adult neurologist seeing Becker muscular dystrophy, there is an important aspect of having them connected with the cardiology team so that they can be followed closely, because they can slip through, and especially as they don't have as much weakness, the cardiomyopathy component may be slipped or may be missed. So in a big center study, which is presented here, if you notice on the right side, there is over the period of 12 years, Duchenne and other causes of cardiomyopathy were led to a severe loss of survival or early death. But Becker patients tend to have a good survival. In a multi-center, 25% of Becker patients underwent cardiac transplantation 5 months after diagnosis of cardiomyopathy, which is a big number when compared to other diseases or other neuromuscular disorders which we see. The survival curves in Becker compared to Duchenne and other cardiomyopathy is really good. So that's a good outcome, and that encourages us to be more aggressive with Becker boys. So the Becker history studies are relatively less, and so as you have highlighted before on the two big studies which have been done, there's not enough enrolled patients and also not enough data, and every center has only a few number of patients which they are following. So it would be good to put together this as in a registry And so I put up a mover link here so that you can be seen and could be included in the studies in the future. I'm going to go over a case study now, and we can do some final conclusions then. So this was a patient, a teenager, who presented to us in the clinic, a 14-year-old with elevated muscle enzymes in an emergency room. He was going to the gym and felt exhausted, had muscle pains and dark colored urine. He was admitted that afternoon and had fluids, and obviously his kidney functions were checked and were normal. He improved over a period of time and he felt better, and his CK was starting to trend down, but did not resolve completely. And the family was referred to the neurology clinic. No family history of neuromuscular illnesses or any particular previous such episodes. And on exam, he appeared very strong, no calf hypertrophy, and with negative Gowers. So, any particular patient in this kind of setup would be a concern for his exertional rhabdo. But because his CK was not trending completely down and took many weeks to months to not completely resolve, underlying predisposition for a genetic etiology needs to be worked out. So in that particular plan was that day was to kind of advise a repeat CK, which still was high. We get a genetic neuromuscular panel. In this particular scenario, being a boy, you wanted to make sure that, again, this is not a form of mild muscular dystrophy or other kind of metabolic myopathies. Hydration and avoid heavy exercise. And we were talking about stretching. We were giving some therapies like aquatics, and was asked if there's any more symptoms to come back to the emergency room. His genetic mutation came back positive. So he had a variant in the DMD, pathogenic variant in the exon 2. And this was also later found to be present in his mother and his younger brother. And we underwent a diagnostic workup after, or further workup after his diagnosis, including cardiac consultation, which showed a mildly reduced ejection fraction, although normal EKG. So this is an example of a case where you come in for more of a rhabdo and not have a very significant finding, but you ended up with a Duchenne gene mutation, and that how should we handle this further? So can we, based on his mutation in the exon 2, can we clearly say this is Duchenne versus Becker? Is more testing needed? Should we start him on steroids or no steroids? And will cardiac care be needed? So going back to the presentation, we just talked about some of the challenges which it faces, especially when there's not a clear-cut mutation which is in frame, and exon 2 being on the out of frame if it's deletion, but if it's a missense or a point mutation or a duplication, it's hard to tell if it's going to be in Becker or Duchenne phenotype. Obviously, just one course of rhabdo and his exam being normal does not encourage him to be on steroids. And the cardiac abnormalities you noted were mostly in a low cardiac ejection fraction, which would require a follow-up. So this was a slide which kind of goes over what would be some of the things we should look from how to distinguish and follow these kids. So for example, if the CK is very high, it can be both Duchenne or Becker. It may not be easy to differentiate. In the clinic, you can do an ultrasound sometimes if available, and you can look at these muscle changes. Obviously, exam would be a good finding, like if it's a neck flexion weakness and the kid is not able to, the child is very weak, obviously that will be Duchenne. But in most of these cases with Becker, they tend to be strong and have normal exam or normal strength. Genetic testing obviously is very helpful, but many of these cases may not have a clear-cut out of frame or in frame deletions. We tend not to use EMGs on these children, but if you do have an EMG and you do them, they could be irritable myopathy, which is quite significant in Duchenne, versus Becker may not have any changes at all or minimal. And then if you have the ability to do muscle biopsy and you can do dystrophin staining, that might be something of maybe useful, like I showed earlier in the presentation, where there's reduced dystrophin staining in Becker versus absent in the Duchenne muscular dystrophy. So how can we improve muscular dystrophy management? I think one of the big things to keep in mind is to have a high suspicion for Becker in boys who have unexplained elevated CK and also non-traumatic rhabdomyolysis or and especially and persistent high CK. Genetic testing is being done more and more commonly, whether it's any common hypotonia or muscle weakness. And I think it needs to be carefully interpreted, as the results can confirm the diagnosis and also help clarify and predict and also give a future course for these patients. Um, Cardiac consultation should be advised, and follow-up should be, we should be encouraged, because if you have an underlying cardiomyopathy, it could be eventually, or it may evolve into cardiomyopathy that can be missed, if especially if the patient is very strong and has no other symptoms. At this time, there's no approved therapies for Becker muscular dystrophy, but a sincere effort to uh, create a standard of care guidelines and follow those patients closely would help. And by putting more registries in place, such as Mover, would also create a bigger data banks for these Becker muscular dystrophy, so that one can understand this disease better. So I'm going to repeat these overall conclusions, and we can then take some questions. Presentation in BMD is quite variable and is quite difficult to diagnose at times, especially as the kids may be, or and young adults may be completely asymptomatic, or may have an episode of muscle breakdown such as rhabdo, or may just present with cardiomyopathy at the onset. Um, Early diagnostic with genetic testing and being proactive with disease management is often helpful. We have seen over the couple of studies with the natural history study that there's not a lot of changes in these patients in the early years, and so first 18 years may be very mild or no symptoms, but thereafter, depending on their exon mutations, their presentation can be quite variable, with someone declining quickly with versus someone who can be stable for a years. And almost we have a family where the grandfather has the same mutation and he's 60 or 65 and he's doing really well. So knowing the family history maybe and it's quite variable. The therapies for Becker are on the horizon. I think the advancements in Duchenne are definitely influencing the Becker management, and would be uh, a nice welcome for the Becker muscular dystrophy group to have some of these clinical trials, which have been ongoing in Duchenne, and help these families. And by widespread participation in patient registries such as Mover and ongoing clinical trials, I think will help move the provide more hope for good outcomes in these patients. With that, I'd like to end, and I'd like to thank the MDA for giving me the opportunity to present on Becker muscular dystrophy and the changes. Thank you.